Now let's look at bone marrow failure syndromes. Important features are pancytopenia, but it's a bone marrow failure syndrome, and there will be this, among this pancytopenia there will be hypoproliferative anemia. So hypoproliferative means retic count is low or inappropriately normal despite anemia. Inappropriately normal despite anemia. That means patient have anemia and retic count should have got increased, but it's inappropriately normal. That's when we say patient has hypoproliferative anemia, means retic count low or inappropriately normal for despite having anemia. So what are the types? What are the differentials of this bone marrow failure syndromes? One is aplastic anemia, another is MDS, third is pure red cell aplasia, and fourth is myelofibrosis. That's infection or malignancy infiltrating into the bone marrow. So broadly we classify pancytopenia with this hypocellular marrow, then we hypocellular marrow and this cellular marrow. And there's a catch. Usually pancytopenia with cellular marrow, MDS is a classic example, but sometimes what happens, there is this hypocellular MDS that falls in this category. So this is pancytopenia, cellular marrow and hypocellular marrow, and this hypocellular MDS falls in this category. Another examples are aplastic anemia. Now see, aplastic anemia can be constitutional or acquired, and most common causes aplastic anemia is idiopathic. So, and inherited causes of this aplastic anemia, they are, one is Fanconi syndrome and another is dyskeratosis congenita. They are the inherited causes. This is constitutional and this is acquired causes. These are inherited causes: Fanconi syndrome and dyskeratosis congenita. Aplastic anemia have pancytopenia with hypocellular marrow. And take note that be it hypocellular MDS or be it MDS with cellular marrow, they have a risk of transformation into AML. So there is definite risk of transformation into AML. Now going back to the classification, we have aplastic anemia and we have hypocellular MDS. Other rare causes can be copper and leukemia. That means there is leukemia, but without high circulating blasts. Fourth is ALL. So this was aleukemic leukemia. This is ALL, and another is lymphomas of bone marrow. So hypocellular MDS. So this hypocellular MDS or aplastic anemia, inherited causes are Fanconi's and dyskeratosis congenita, copper deficiency, ALL, that is this aleukemic leukemia. Then follows this lymphoma, this bone marrow, and finally ALL. Whereas this cellular, the first category was MDS itself. Second is this paroxysmal nocturnal hemoglobinuria. Third is myelofibrosis. Fourth is again aleukemic leukemia. Fifth is myelofibrosis. Other causes can be bone marrow lymphoma and hairy cell leukemia. Secondary causes, for example, SLE, sarcoidosis. So sarcoidosis can cause pancytopenia. SLE can cause pancytopenia. Similarly, hypersplenism. So hypersplenism and B12 folate deficiency. So both can cause pancytopenia with cellular marrow. Hypersplenism, B12 folate, sarcoidosis, SLE, and then copper deficiency again. So what is the setting for copper deficiency? So there must be history of bariatric surgery or zinc overuse. Then comes alcohol, HIV or TB or sepsis, and brucella or leishmaniasis. Brucella or leishmaniasis. So these are the causes. So SLE can present with or without cytopenias. What happens in paroxysmal nocturnal hemoglobinuria? There is this mutation in PIGA gene that leads to CD55 and CD59 deficiency. So there is always a triad you will come across. One is as from this paroxysmal nocturnal hemoglobinuria. So there is this hemolysis leading to cytopenia, and there is thrombosis. That is an odd feature. So hemolysis, cytopenia plus thrombosis. So patient can present with pancytopenia, and when you do routine urine examination, you will see RBCs are there. This hemoglobinuria. So maybe blood will show positive, but RBCs will be absent there. This is shown on dipstick. So this is negative. This is positive, but RBCs are negative. So this is hemoglobinuria, and patient will pancytopenia plus you will see thrombosis. For example, DVT or any other thing, you will see such a presentation, and you have to diagnose this condition by flow cytometry. And because hemolysis will be not antigen or antibody mediated, that's why it's Combs test. It will be Combs test negative. Now this terms splenomegaly and hypersplenism are related, but they refer to different clinical concepts. And what is splenomegaly? We know that enlargement of spleen, it is an anatomical finding that is based on size, whereas hypersplenism is a functional disorder where the spleen is overactive and destroys blood cells excessively, RBCs, WBCs, platelets. It may or may not be enlarged. So splenomegaly is structural or anatomical type, whereas hypersplenism functional. So presence of cytopenia is not necessarily present in splenomegaly, but yes, typically pancytopenia or bicytopenia is present in hypersplenism. And we know splenectomy is not always indicated, but cytopenia gets reversed by splenectomy in hypersplenism. Presence of symptom, yes, it causes symptoms due to cytopenias in hypersplenism. So causes of hypersplenism, for example, a patient has cirrhosis with portal hypertension or hematological diseases or autoimmune disease or primary hypersplenism, although that's rare. Hypersplenism diagnostic criteria, if we see, one is patient should have splenomegaly. They usually have the splenomegaly. Second is patient has cytopenia in greater or equal to 1 cell lines. Third is patient should have bone marrow showing normal or increased production. Fourth is correction of cytopenias after splenectomy. So diagnosis of hypersplenism is patient should have splenomegaly greater or equal to 1, cell lines should have cytopenia, normal or increased production in bone marrow, and reversal of cytopenias. Whereas splenomegaly is an imaging diagnosis or physical examination diagnosis defined by spleen size. For example, greater or equal to 13 cm adults, we have various cutoffs. For example, if a patient with pancytopenia and massive spleen comes to you, he especially in a setting of cirrhosis or for instance CML, so what possibly could he have? He could have hypersplenism. So hypersplenism is simply overactive spleen removing cells. That's why you have to check marrow to confirm production is intact or not. So if you check marrow in such cases, so I will give a quick algorithm to differentiate. For example, you find that patient has splenomegaly, then you check whether there is cytopenia or not. If yes, if there is cytopenia, so this could be this so you have to suspect hypersplenism. Second, then you have to check marrow. If there is increased production of cell lines, then this is definitely hypersplenism. But if decreased production, then this is bone marrow disease. So for instance, we will take an example. Patients having myelofibrosis like this, so this category, what happens in this patient? You will always find these myelofibrosis patients have massively enlarged spleen. They have massively enlarged spleen. Why this occurs? So what happens in myelofibrosis? We know that spleen, there is bone marrow is not able to produce enough cells. There is fibrosis in the bone marrow. That's why we get dry tap sometimes. But in myelofibrosis, there is the spleen becomes a site of extramedullary hematopoiesis. So there is increased cell production in spleen. So cells are increased, the production is increased in spleen, but at the same time due to hypersplenism. So hypersplenism is a functional disorder of the spleen. So what it does, it destroys cells. So cells are sequestered, so spleen sequesters and destroys blood cells. So both, this is a production, so this is production and this is destruction. They are happening simultaneously in the same organ, that is the spleen. So that's why bone marrow is fibrosed, hematopoiesis shifts to extramedullary sites like spleen and liver. The spleen enlarges massively due to this hematopoiesis. However, the spleen also becomes a hyperactive reticuloendothelial organ, filtering and destroying cells. So net effect, we can say net effect is often mixed. It's mixed. So it's often insufficient to normalize counts. So dual role of the spleen explains why patients have huge spleens but still have low counts. Splenectomy in selected patients may improve blood counts by removing the site of sequestration, even though some extramedullary production is lost. So we can also frame a question here. In myelofibrosis, spleen becomes a site of extramedullary hematopoiesis. Despite this, patients develop pancytopenia. Why? Answer is because of coexisting. So because of coexisting hypersplenism, which leads to sequestration and destruction of blood cells within the enlarged spleen. And note that paroxysmal nocturnal hemoglobinuria, as we discussed, like here this PIGA gene is defective, CD5550 9 is lost, leading to dystriad, hemolysis, cytopenias, thrombosis. And note that it is only marrow failure syndrome that's associated with thrombosis. Only marrow syndrome. And usually thrombosis we find in hepatic and mesenteric veins. I mentioned somewhere zinc overuse that leads to copper deficiency and leading to pancytopenia, hypocellular marrow. So how does this occur? So you see, zinc does competitive absorption with copper, leading to copper deficiency. So this it is a MDS mimicker. It's an MDS mimicker. And note also that MDS can present subtly with this macrostic picture, macrostic anemia. Can present with macrostic anemia and other cytopenias, especially in older adults. Now there is this, we read pancytopenia with this hypocellular marrow and cellular. Now there is this, either some categories are hypocellular marrows but with or without pancytopenia. So what are the causes? One is Q fever, another is anorexia nervosa, third is Legionnaires' disease, fourth is mycobacterium infection, and this is starvation. Another is starvation. So Q fever, anorexia nervosa, Legionnaires' disease, mycobacterium infection, and starvation. These are the causes. Now let's go to aplastic anemia. We'll discuss this aplastic anemia in the next lecture. Kindly share, like and subscribe. Thanks.